Of course, as Jared, you alluded to, there are other agents being tested in the first line. There's a randomized study with durvalumab looking at it in similar fashion to what you described, although there isn't a combination chemotherapy arm. And again, data that I think we're all excited to see.
Well, that one has the combo immuno, though. So the Kestrel trial has the extreme 2 to 1 to 1 at least, so only 1 in 4 chance of getting extreme, but extreme versus durva alone versus durva-tremi, so that in one trial we'll get some comparison not only of cytotoxic versus immuno, but what benefit the second agent adds.
Right, and so this idea of targeting 2 different points in the immune cycle, one a synapse that's within the tumor of PD-1, PD-L1, and then another one that predominantly affects the lymph node or presentation of the antigen in CTLA-4. And so, Josh, let me turn to you about immunotherapy combinations. Which ones look promising, which ones look exciting and are being taken forward?
So I think that the CTLA-4 inhibition, either with tremelimumab or ipilimumab, is certainly being evaluated aggressively. The limitation, of course, with CTLA-4 blockade, while it has biologic plausibility, is in contrast to the description we've given about PD-1, PD-L1 inhibition, there's significant toxicity that's associated with these drugs. And so while it's exciting to use them, I'm concerned in a biomarker blind environment giving all of my patients a combination of PD-1 and CTLA-4 inhibition. And what we've seen in prior studies from other tumors, specifically lung cancer, is a relatively inconsistent story regarding the role of PD-L1 staining amongst patients who receive the combination PD-1 and CTLA-4 blockade. I think we end up speaking out of both sides of our mouth. We say on the one side, we say, oh, well, you know, if you give CTLA-4, you don't need PD-L1 expression. And on the other side, you say, oh, but look, in PD-L1 strongly expressing lung cancer patients, ipilimumab plus nivolumab leads to a greater than 90% response rate. So we have to pick which one we're going to go with.
We'll find out from studies.
We'll find out.
Crazy thought.
But one of the exciting studies that was presented at ASCO this year in multiple tumor types, including head and neck cancer, evaluating the combination of pembrolizumab with epacadostat. And epacadostat is an oral IDO inhibitor. And this is another checkpoint involved in the immune system and seems to have synergistic effect. The nice part about epacadostat is it's really well tolerated. In the study that was presented in head and neck cancer, a little bit of increased fatigue than what you'd expect from just PD-1 blockade alone, but outside of that, pretty well tolerated. And I'm much more likely to get excited about a biomarker blind application when we are using it with a well-tolerated drug.
Absolutely.
And can I just follow up on what you said about biomarker? There are some patients who are going to do just great with Nivo or Pembro alone, right? And so one of the things is you'd like to know where you need to add CTLA-4. You'd like to know where you don't need to add it, right? So.
I think it gets more and more complex when we begin to invoke a second and perhaps in now some clinical trials a third immunotherapy agent. So couldn't agree with the panel more that as we're excited about doing the clinical trials, we have to be just excited about figuring out which patients should go on which therapies. Of course, another doublet that was recently presented was the combination of nivolumab and lirilumab, which is an anti-KIR antibody that also showed an increase in response rate without a significant increase in toxicity. So I think the idea of using different mechanisms of action that affect the immune system is something that we're going to see a lot more of going forward.